Shastra Shelika.
And above them, the second layer is Shastra Kormi. They are the community health worker.
She is supervising 6 to 10 of them, and also she is visiting households.
So the SK is supervising the SS.
SS,
Yes.
yeah, SK is supervising the SS.
Assalamualaikum. My name is Nazmin Parveen, Program Organizer.
So each program organizer, they supervise the health workers.
They are our staff.
Oh,
Even they also back paid staff, Shastra Kormi. But depending on their work, they also get incentive. But the Shastra Shevika, they are totally voluntary incentivized worker. Based on their performances, they get the incentive.
So the Shastra Shevika get like a
Shevika,
kind of
they
a
are
commission,
the-
but they get a commission or incentive as well because they're voluntary, but they get a commission.
We give them incentives, performance-based incentives, and also we have made them self-sufficient so that they can sell some of the health commodities. What we have said, you will talk to her, she will show you that what she has learned and what are the commodities she can sell, and also she can give services at the community. Because she would visit households at her convenience. She would cook in the morning, maybe she would go when she is free. But they have to start in the morning, visit all the households of her areas, 10 of them, and complete in 6 months.
So,
I'm Sadia Malik, Senior Branch Manager.
একটু সামনে আসেন,
Like the Gulshan, we have mentioned that the Gulshan proper branch, so she is the branch manager.
So the Shastra Kormi get a monthly salary
Yes.
from BRAC.
Along with it, some performance-based incentives.
Okay. And the Shastra Kormi, I'm just trying to understand for the purpose of our project as well. So the Shastra Kormi, what kind of training do you give versus Shastra Shevika?
I need to add Korea because I was already discussing. Shastra Shevikas, when they are recruited, we provide them a basic training of 15 days, but we have refresher trainings. Initially we had it monthly, and now we have it quarterly, bi-monthly, but we say it, a training is not complete unless they complete a year or two, because they are just learning from the beginning, from scratch, because they are from the community. So the continuous training are there, and also when you recruit Shastra Kormis with a bit of education level a bit better, at least they have to be 10th grade, and now we are encouraging even we getting 12th grade. So then also we give them training. The training they receive are more of like paramedics, but also with the 12 days training, and along with it every month and some special trainings. They would visit their households with a register, and now they're replaced with the mobile in this area. So she would inquire about family planning status, and also along with it they would do the household surveys, and also when she identifies a pregnant woman, she informs her. She would do community-based, home-based antenatal visits, antenatal care, postnatal visits, and ensuring about exclusive breastfeeding. And when they complete 6 months, they would initiate and demonstrate them. Both of them would go and start complementary feeding and other activities also. They would do the visits while doing it. So they are trained for these things. Like initially, they were just doing blood pressure checkup and some examination. Recently, we have introduced Talquist hemoglobin test, urine albumin. So they are doing that now at the house. In pregnancy period, yeah. And also they are doing postnatal visits, so others. So this is how they get the training gradually one after another, and need-based training.
Test for infection?
Not really, only for the albumin, because infection we need microscope and all these things.
There's a new test, well not new, it's quite old, it's for leukocyte esterase. It's a strip test.
Yeah, this is also strip.
Yeah, but it's got it checks leukocyte esterase. And it's available. I'm the doctor. Maybe you probably think that you put it's got lots of in albumin there's just one spot. But this one has 4 or 5.
We can show you
we
what
have
we
also
have.
this kind of strip.
I think we have it, but
So the leukocyte esterase, it is a you can detect infection on this.
yeah, they say it, but we don't emphasize on that.
Yeah.
Maybe we
because for antenatal care, infection is vital. Infection will lead to premature delivery. Half of our low birth weight, because one of our priorities is low birth weight. Half of the low birth weight is due to premature delivery. So if you can prevent premature delivery by detecting infection early, that's it. Leukocyte
আমি একটু ওনাদেরকে আপনাদের সাথে ইন্ট্রোডিউস করাই দিই, আপনারা একটু আসেন।
So say if you have large number of leukocytes, see? So this is leukocyte, and this one and nitrites. এই দুইটা মিলে infection is more or less not like culture, but as good as microscopy.
Then we can also
Please,
tell
we need your
them.
antibiotics.
Also,
the thing is, we just
But you have to collect it midstream, and you have to collect it properly in a midstream urine. So that is vital. But if you're supplying these, how much does this cost?
330 taka per box.
But
how
per
many strips
strip,
inside?
There are 50.
yeah, because we customize it, we ask the supplier to give us 50 strips,
Yes.
so that if it's 100,
Yeah.
then there might be the quality might
Expired.
go down or
Yeah.
something. But each
Excellent, you're
test
using this.
costs quite low.
এই লোকটা কোরিয়ান না?
Chinese one.
China, right?
So the thing is, we just introduced it last month.
That's right.
From last month, we have our health workers. They are taking this device and also along with some other devices to the field to provide this.
also we have a Bangla translator, so if you speak Bangla, he can translate to Japanese if you need to.
অসুবিধা নেই, আমাদের জন্য ঠিক আছে।
Our health worker, they will talk in Bangla.
Yes.
That
So then
time,
they
the
translate.
communication has to be in Bangla.
Yes.
So if English is not a problem for you guys, I mean, then you can get it.
No, I think they understand your English. I'm saying
yeah.
I'm saying later on if you move to
When
Bangla,
you
the
talk to them,
translator, yeah.
তখন
will do
থাকবে।
that.
আরেকজন, another cadre here that we can't miss, she is the Manoshi midwife. So they are now our new midwife, like they are now, I would say, community midwife, they are paramedics, but they are conducting the deliveries, they are doing antenatal care also at the center. The Kurmis are doing at household level, but they are doing at the center. And also family planning the services they are providing and conducting some meetings of the mothers. So they are, আপনারা একটু আসেন, আপনাদের একটু পরিচয় করে দিই, এখন ইনভেস্টিগেশন লাগবে না। আচ্ছা, ওনারা এসছেন জাপান থেকে, আর ওনাকে আমি পরিচয়, আপনি জানবেন যে তালুকদার স্যার আমাদের বাচ্চাদের একজন ডক্টর আছেন, উনিও কিন্তু ওনার ছেলে তালুকদার স্যার, উনিও আমাদের মানে আমরা ডক্টর তালুকদার হিসেবে জানি। আর এসপি ভাই উনি এসছেন, ওনারা টেকনোলজি, আমরা মোবাইলে অনেক রকমের পরীক্ষা করি, এই ভিজিট করার সময় দেখি না, ওনারা এই টেকনোলজির মাধ্যমে অনেক কিছু পরীক্ষাও করা যায়, সেগুলো ওনারা নিয়ে গবেষণা করছেন। তা আপনাদের সাথে একটু দেখা করতে আসলো যে কিভাবে আমরা কাজ করি, ওনারা দেখবেন। তা আপনাদের সবার কাছ থেকে ওনারা কথা বলবেন, আপনার কাছ থেকে আপনার কী কী কাজ করেন, কী কী শিখেছেন এগুলো দেখাবেন, আপনার মোবাইলটা কীভাবে আপনি বাসায় ভিজিট করেন, এমন হতে পারে আপনার বাসায় যেও দেখাতে পারেন, আর আপনি কী কাজ করেন, আপনাদের দায়িত্ব আপনারা আলোচনা করবেন। তো এই হলো আমাদের পরিচয়। এখন তো বসবাই যদি একটু আমাদের ছবিটা দেখে দেন।
I will tell you about a brief about the program so that you can answer the questions and all. So the thing is, we provide community healthcare service at the community level to our health worker at the doorstep of the families with patients. Like our Shastra Shevika and Shastra Kurmi, they have some selection criteria. Like she has to be educated, she has to have a class 5 to 8 pass, so she should have some sort of literacy so that she can read and write. As well, upon selection, we give them a basic health training, and they also get a refresher training by month nowadays. So they will be they are selected from the vicinity, and on the vicinity we assign them for their work. Like she will be responsible for now it's 350 households, 350 to 400 households. Which Shastra Shivika will be assigned on around 400 households. Okay. And so she will visit those households and she will look after those households if there is any problem. You know? So like if there is any anyone is pregnant, like anyone missing period, they will ask the history. You know, by that they get to understand that there might be a pregnant lady. Then she will inform the second level health worker, her supervisor, the Shasta Kurmi, and Shasta Kurmi will go to the mother's house and check the mother's status, whether she is pregnant or not. Shasta Kurmi have been provided with a pregnancy strip test. I mean, they have a pregnancy strip to confirm the pregnancy. Whenever they confirm the pregnancy by a urine strip test, they enroll the mother into our system. Like for this region, we have mHealth for the data collection, for registration, for providing the service. We use this app. It's an Android-based app. So we will show it to you. Okay. So
Ask about the number of the households covered. We cover 250 per Shasta Shebika.
We cover 350 to 400 per Shasta Shebika, and
So the
each
population is about
population will be about 3,000
per Shasta Shebika. 3,000. Yeah. Household is about 4 per household.
Household is like 4 per
So
household.
this is about 1,200.
Sorry,
1,500. About 1,500. Okay. The 1,500, the number of deliveries is Bangladesh is about 20 per thousand. So if you have 1,500, you will get per year. So in a year, in those number of households, you get 1.5 deliveries. So this Shasta Shebika is responsible for, in a year, she will look after one woman going through pregnancy, 1 to 2. So it's not a very big workload in terms of pregnancy.
In terms of pregnancy and also, it's like
Yeah, so that's the care will be excellent. I mean, the ratio is so good that yeah. Go ahead.
so also along with identification, they have also some sort of services to provide. The Shasta Shebika, they can also, I mean, they have other careers of services. Like they can sell 10 pre-prescribed medicine for 10 common diseases. Like for fever, they have paracetamol within their bags, within their commodities. We supply them with some commodities, and within the commodities we have paracetamol for fever, they have sanitary napkin, a lot of other oral saline, family planning methods, oral pill, contraceptive, condoms. So they also can sell these commodities to the community, and I mean, from there they also have incentives.
Do you need antibiotics?
For
The Shasta Shebika is carrying
Well, only for the pneumonia, they use
for children.
They were using cotrimoxazole, but now we are shifting to amoxicillin. So this is a new circular already has arrived here. Because we have to give them whatever we start, we have to give them a bit of training. So we will provide them because we have a revolving fund for the Shasta Shebikas where they can buy and sell out because we have to supply them with a subsidized rate.
Do you give antibiotics for UTI, for pregnant women?
Well, not the Shasta
Not for Shasta
Shebikas,
Shebika.
not even the midwives. We have one doctor here in this region. She would be here because she would be visiting together NDD Center, a Neurodevelopment Disorder School here. So she would visit, that's why she's there. So she is here every week, for once a week, because this is 24/7 open. So the midwives, they do antenatal care and everything. Maybe in future we will promote for the other women and for the midwives. But the doctors once a week, she can do antenatal care, also visit checkups, and also women's health, any complication for the mothers. But above all, we have a very strong referral system. So we can refer them anytime, any complication in antenatal period, during delivery, post-delivery, newborn, children under 5, we refer them. The referral system is a very big strength.
And you referring?
Most of the complicated cases, yeah, but we have some MOU with the local NGO clinics, which are run by the local government, urban
USA
then urban primary healthcare
urban
projects,
primary healthcare
projects also.
ওখানে ডেলিভারি করে
Some of the places,
কমপ্লিকেটেড গুলা
yeah. And not they don't address complicated
নারী
cases.
মৈত্রী যেমন আছে, ওরা ধরেন একটা একটা লেভেল পর্যন্ত ওরা ম্যানেজ করতে পারে সি সেকশনও করছে ওরা
Or C-section?
সি সেকশন
Some of the places.
Narimantri is an NGO.
NGO, but they are the family health representative under the Tata Hospital. So there are a lot of organizations like this. Hospital.
Are you referring to Mary Stokes?
Yeah.
Mary Stokes also.
They also
have
do
MOU.
cesarean. They do cesarean.
They've got different centers. Some are satellite, some are, with facilities and all. But we have MOUs with them because we set up that they have to also support some of the people in a subsidized way. So when we have MOU, they have to provide
Charges.
support. Yeah.
What's the charge for a cesarean section?
We have MOU for the with Maristops and for Smiling Sun and other as well. 6,000 taka, 500. Some are
6,500.
Yeah. Some are in premium, some are less than what they can't.
Right.
But
The whole
they're-
package, antibiotics, everything.
Yes.
Yeah,
That's
including 3
fantastic.
days antibiotics.
That's amazing. And they keep them in hospital for 3 days?
Yeah.
6,500 for a cesarean
But,
section.
now it's
That's
not
less than
possible.
$100. No, now it's coming up.
Yeah, coming up. And this is how it's because some are common funded, some are responsible.
Changing situations,
Yeah.
yeah.
So we have to. But the thing is, during the complications, mostly eclampsia, PPH.
You have to go to Dhaka
So
Medical.
we don't. We try to save time. The second delays we try to avoid. We're addressing all the delays, first, second, and third. So second delays are
Just
like
tell them
the-
what first, second, and
okay.
third delays are.
First delays are like decision making for the mothers or the family members to take to the hospitals, and also our community health workers, our midwives. So this is we try to reduce, like bringing them here to the center, not at home. So to decide, so that we can send them. So we have MOU with some ambulance services, but we don't wait because you are here, so you
can't
know
get an
the
ambulance
traffic.
here.
So ambulance would come here and go. That's a horrible
Impossible.
situation. So
How do you
we
take them?
send them whatever vehicle we get.
Rickshaw van.
Rickshaw van. Oh,
You can
well,
take a
Dhaka
camera.
we don't need
Like
rickshaw van.
we,
We have a
like in this,
stretcher.
in this.
You can take it. Stretcher.
Like
Yeah,
in
we
Islam,
have
we
one.
have we tell the mother, you communicate with some other vehicle driver,
Yeah.
those who
During the
resides
birth planning.
within your community.
Before.
During the
Yeah,
work planning.
and also we give them a book, MCH handbook.
This one?
And within this one, and within this book we also
all the
tell them
messages.
to put a driver's number.
Yes. Driver's
that-
number. At the
so that
emergency.
in case of emergency,
Yeah.
you communicate with him or her and check out the patient
Make
as
your
early
way
as possible.
as early as possible. Right.
So as well, we have a stretcher if
Yes.
they have to go.
In
we
these
can-
places, no
yeah,
rickshaw.
yeah. Rickshaw is not quite.
Who carries the stretcher?
People, you know.
Just the neighbors and.
The neighbors, in this community, they have a
They're very close.
Let me just add two things. Like when you work in a community, if you don't involve the community, it's a challenge. We faced challenge in the beginning that they were resistant. So we formed committees. We call them MNCH committee. They are the local leaders, religious leaders, teachers, some local elites here, and our community health workers. So these committees are a very big strength for decision making, for the first reducing the first delay. Even for the second delay, they would arrange. Some are the landlords, some owner of the the rickshaws or the CNGs.
Second delay is the transport.
Yeah, the transport. The transport is the second delay. So to reduce that, what he mentioned that we have arranged all these things, and all we do. Have you mentioned about the household visits?
Yes. Yes.
Yeah. So during the household visits, our Shasta Shebi Kurmi would ask them about the birth planning, because this book has got, like in Japan, MCH handbook.
Yeah.
And Yasuhide Nakamura, Sensei Nakamura, he visited, and we had good communication with him, and we participated in the MCH handbook conference, and his name is also here.
He's one of the advisors.
Yeah, initially we talked to him, and also Dr. Shafi Guya, he was working with him in Osaka. So then we developed this MCH handbook at a community level, because there had been some research here in Bangladesh, some of the places piloted, but we just scaled it up. But this is a community-based MCH handbook, and you can see most of them are pictorial, and we are at the development phase developing. He's one of the team members who are developing now further developments, because we just, whatever BCC materials we had, we just put them all together here, because like these are the danger signs, the poster you can see. The mothers, it was a taboo for the mothers, and also they would not prefer, because when we identified a pregnant woman, they would stick a poster or sticker, and they said no, even for the religious related thing, and also a fear of these danger signs for the mothers. So they used to remove it. So what we did that, okay, why not we put it in one book so that they can see whatever. So this is how this book has got birth planning information. So we write who would carry you in case of emergency, who would be your blood donor, how much money you have saved, everything. So the meeting, if you could see, these things, everything the Shasta Kurmi would say at household level, at their last trimester we invite the mothers here. Not very crowded, maybe less than 10 mothers. There's one meeting going on.
The EDD meeting.
Yeah, expectant. Yeah, this is EDD, but it's mainly of expectant mothers meeting.
Oh, expectant.
Yeah, but we call them EDD meeting.
Expected date of delivery,
Yeah,
EDD.
delivery.
So,
So it's easy for them
planning
to
for
say.
that day. It's excellent. It's wonderful.
And that meeting recaps everything,
Yes.
whatever has been discussed by them and the midwife, and also orient them to this place. But one thing, that when they visit households, if they identify any high-risk mother, we have categorization, who has previous history of C-section and other categorized. We don't deliver them here. We refer them directly to the hospital, because this is a simple delivery center, I mean birthing center. We can't address the complications and all, but in this center, they can address immediate PPH, they can manage episiotomy.
Can they give IV fluid?
Yes, of course, the midwives can do.
Excellent.
So these are some basic things.
Just
what we-
support initially and then
supporting
transfer.
that, so that when we do, because you know even for the transport, some mothers die on the way during bleeding. So if we have an IV fluid, at least we try to save.
Yes, yes. And the third delay is in the hospital itself.
Oh, that is
That's the worst delay.
yeah, and most of the deaths are there.
Yeah.
But up to a referral period of time.
So let me get a minute brief.
Yes,
I mean, along with EDD meeting, these are BCC tools. I mean, the behavior change communication tools for the mothers, like MCH committee, and we have other one of the other. Maybe I can get it later. Upon also registration, we are providing. Official broker is providing. They are providing the service at the doorstep. Once in a month, they go to the mother's house and provide the antenatal care. And they do the basic examination, physical examination, like checking the blood pressure, anemia, jaundice, fundal height of the pregnant lady after 5 months. So, and they put this information in the mobile app and they send it to our central server. Okay. So as well, they do some basic physical, investigation.
Do they weigh them? Weight?
Weight, they also take.
Monthly weights, so it's been going up.
Yeah. But not in the field, but when the mother comes in our maternity center, we have this weight tools, so they can weight gain.
So pregnancy weight gain is an issue in nutrition. Traditionally it's been in the West, they get, according to BMI of the pregnant mother, how much weight she should gain. For Bangladesh, because of the limitations, people say 7 kg is enough. But you don't think this is right. I mean, this is not. We've just made that figure. But what sort of weight gain are you getting here? You know?
Around I mean, that is the common,
Yeah,
7
7
to 10 kg.
Yeah, 7 to 10.
They don't get enough nutrition.
Yeah, they're not eating enough.
So more or less it's like 7 to 10.
7 to 10. Yes. Okay. And low birth weight rate? How many low birth weight are you getting per?
Like we can tell the exactly percentage.
14%, 1/4. There's been no low birth weight national survey since 2003. I mean, it's a big scandal in this country that we don't know what our low birth weight rate nationally is.
Now 24.
Yeah, but that wasn't.
In our
Where did you get? Where did you?
14%.
Where did you get 24?
For global weight, all of the country.
Well, that's the thing. There's this weight
Oh,
gain.
the biggest
বিদেশে কোনো low birth weight data নাই মানে ওইটা কোথা থেকে আসছে they did that they asked the mother was your baby small or big And it's a mother perception data. So it's
I know that right. They published our national global estimate nothing.
Hasan bhai, ওইটা যেটা আছে, that's not the perfect data.
the real one was done in 2003. We did a UNICEF or BBS or something.
It's like, for Novartis, you have to measure the weight. In BDHS, they were asking the mother
What is the
how
size?
much. I mean, yeah.
So anyway, so we data 36 and 37%. That was 36% in 2003. But you were probably right. It has definitely gone down. And you're seeing in a slum, you are seeing 17%. Is it? What did you say? 14%. It's fantastic. So this is an indication of the economic uplift and the progress in Bangladesh. And but nationally, we don't have a figure at the moment. But that means if it's 14% here, nationally it must be much lower, huh? Because Islam is 14%. So in the rest of the country, it's probably what 7%, something like that. So
He's talking about this thing.
Yes.
I mean, this
Gulshan, which is a rich area.
But even for our
Rich slum.
even for our home data,
Yes.
like the Monash is covering 7.1 million population, 11 city population.
Yes.
It's on around 9 to 10. You know,
Yes.
the lower is 9 to 10.
Only 9 to 10.
Yes.
And so this is the worst. It's 14%, even though it's the richest area.
Oh, low birth
Yes,
rate,
low birth
yeah.
rate. Nationally, আপনাদের সব সেন্টার মিলে it's about 9 to 10%.
আমাদের কম আসে যেখানে অন্য জায়গায় আমাদের তো বেশি আসে নাকি?
14%.
এখানে 14%.
হ্যাঁ কিন্তু ন্যাশনালিতে একটু আবার
না, ন্যাশনালি মানে আপনাদের অন্যান্য সেন্টার
অন্যান্য সেন্টার সহ, অন্যান্য সেন্টার সহ
আমরা
টোটাল
তো
মানুষ
ন্যাশনালের সাথে কম্পেয়ার করি বিকজ আমাদের তো অনলি উই কম্পেয়ার উইথ ইন্টারভেনশন এরিয়া
in the slum area. Your intervention is just in slum.
Just in the slum.
So that is you saying that it's 9 to 10% in the whole country. In the
no,
slums.
not full country, not
Whole country
Manush
is-
program.
Manushi program isn't it in the whole country?
It's 11 city corporation area. That's only 7.1 billion population.
That's a large sample size for it is representative of the slums.
It
You have such a
I'm talking about the 2015's last data.
Yeah.
But nationally it's a bit more because you know it's covering others and other rural areas here. That is, we also working in the rural areas.
Do you have low birth rate data for rural?
Yeah, of course we have. But we are working in 14 districts for the rural areas. So we have data for that 14 districts. But one thing I forgot to tell you that our whole health is based on essential healthcare program. And that's we are covering almost all districts. In 61 districts, some districts are maybe we are yet to address it. There, our community health workers are there everywhere. And they are visiting households, sending products the way she does. The Shasta Kurmis are there, but in MNCH areas is more intense, more comprehensive compared to those areas.
They measure birth rate, the MNCH. In the essential
And then essential healthcare, I don't think they measure birth rate because they have got Salter scale because of it.
Can you show me a Salter scale? Just show you the weighing scale that is, and it's not digital, is it?
No, we, you know,
Are you saying you're getting a digital?
Garchini,
Yes.
Dr. Abhema.
Garchini.
We went there and we learned a lot of things like, you know,
India.
there are, even at the government level, there is no postnatal visits for the newborn.
Yes.
So we took the experience from Garchini and we introduced during the postnatal visits, we also address the newborn.
Right.
Where, like we have in MNCH, we have got within 24 hours we have to visit, within 72 hours, within on the 7th day, and then on the 28th day, when they complete the neonatal period, and then on the 42nd day, for the mothers to accept the family planning method. But if a low birth weight, we give an extra visit, that is on the 14th day, so that the baby is progressing. And initially we had baby jackets for the babies. We used to provide for the newborn.
So this is like goes up to 5 kg, and it's 100 gram accurate. So can you see 100 gram
This
accuracy?
is called Salter scale.
Maximum is 5 kg. You don't expect in Bangladesh baby heavier than 5 kg. It's very rare. Okay, so this if it goes above the red is good.
Above there it is 2.5.
Nothing. আড়াই কেজি কোথায়? আড়াই কেজি? Oh, sorry, right. ওই লালে 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 মনে হয় লো বার্থ ওয়েট না? হ্যাঁ আর ও আচ্ছা 2 কেজি 500 this is the cutoff for low birth weight, okay? So when the baby is heavier than this, it's in the green, it's good. If it's lighter than this, then between 2.5 and 2, this is, it's also not good, but under 2 is very bad. Yeah. That is very dangerous. That child is extremely at risk and can die, very, of the slightest infection. So that's now. Is it? Do you know if there's a digital version of this available?
There are some digital weight machine. We have seen in our head office. Hand code. It's like this digital. But we are bit
possibility of getting
so
it also.
we were a bit unsure about the quality of the digital one. So
That's why you didn't use
that's
it,
why we didn't use it now. So that might be your case of
Because we need digital to put into the.
But in
So-
the beginning, when we started our program, firstly we took this experience from Dr. Abhay Bhan, and here they are visiting households. So and convenience, economic, everything we needed, and for to lift the baby, accuracy is also important. So that's why we thought that Sauter scale was
The best.
best option. So that's how we
And the
started.
mothers you use in bathroom scales?
Here, yeah, when we visit other rooms,
That's
I'll
digital.
show you.
That's digital.
No,
Not
not
all.
yet.
Not yet. Okay.
Because
But those-
we have to make it very economic.
Yes.
Area.
Digital scales now are about cheapest. Tanita is a Japanese company, but they're made in China, and they're about 3,000.
Maybe some of the new centers, but where maybe because this is the procurement they decide. So wherever they get in a lower price, they get that for us. And another thing for the newborn care, because some knows, so I should tell you that they're all trained, our midwives, in helping babies breathe.
Oh, fantastic.
Everyone. So this is we try
Which
to
explain
ensure.
to them what that is.
Helping babies breathe is a doctor, Mr. Ledrell, I think, from
Leerdal,
Ledrell,
the
yeah.
company who
Yeah,
makes all the
company who
resuscitation
make,
equipment.
It's a community
Norwegian.
based how you resuscitate a baby.
Who's
during
not breathing
birth,
it,
if
not
birth
breathing.
asphyxia. So this is a very, very innovative way how they have got different ambu bag and they have got penguin suction and everything. So the training they have received, and also we can measure the birth weight also here. And when we started also, the low birth weight we provided the mothers a baby jacket. To the mothers initially.
Low birth weight.
For the low birth weight. That was in the beginning, and
To keep the baby warm.
we keep the baby warm. But now we are promoting kangaroo mother.
Kangaroo mother.
That is very
KMC.
Very KMC. You would know, like the kangaroo, they put a baby, so it's skin to skin contact of the babies.
But
So
is
this
it-
is we are promoting.
is
But
it-
we are facing.
জামাটা আছে?
না আমাদের ওটা নেই, আমরা তো এখন ওইভাবে করতে পারছি না। And but in our climate, weather,
Very sweaty.
The mother sweat and all this, then the baby gets more
Wet.
dry and wet. So that is a challenge.
Yes, it's
So,
challenge.
but still we are providing baby jacket if it's low birth weight in the winter time, because in warm it's
এখানে
very hot.
সবচেয়ে কম ওজন, lowest birth weight you saw, what was that?
এটা আপনি বলেন, আসেন, আপনিও তো জানেন।
সবচেয়ে কম ওজন বাচ্চা এখানে আপনি কি ডেলিভারি দিচ্ছেন?
এটা এই মাসে
সবচেয়ে কম?
1 কেজি 600।
So the lowest birth weight they've delivered in this center is 1.6 kilo. And the child survived. And that child was sent home on breast milk and was sucking all right.
But one thing, if a baby has birth dyslexia,